We have two speakers to start us off. Any of our speakers and any of our panelists could speak about all of the kind of data we may care about using. We've asked them to constrain themselves just a little bit, at least for the sake of formal remarks. And so we can show you a little bit of large public data set, which, as it turns out, collects the breadth of type of data. And that's from the All of Us network. And then we're going to talk a little bit about EHR data and in particular, the creation of federated networks and ways to make data quality better. And so with that sort of context, I'm happy to begin by introducing Jordan Smoller. So Jordan is a psychiatrist, epidemiologist, and geneticist, and you can tell by even those three terms just how wide his expertise and perspective is. He's the Jerrold F. Rosenbaum Endowed Chair in Psychiatry at Mass General and a professor of psychiatry at Harvard Medical School. His research focus has been on understanding the genetic and environmental determinants of psychiatric disorders and using big data to advance precision mental health, including improved methods to reduce risk and enhance resilience. Relevant to his talk today, he is the lead PI of the New England Precision Medicine Consortium as part of the NIH All of Us research program and co-chair of the All of Us Science Committee. So Jordan, thank you very much for joining us.
Thank you. Thank you so much, Niteesh. And thanks everybody for coming. And I'm delighted to give you an overview of what I think is really a national treasure. And hopefully some of you have already encountered this, but I want to sort of give you the landscape of it. I'll just correct that I was the co-chair of the science committee for several years, but now I've rotated off that position, just to be precise. But I'm going to introduce you to the All of Us research program. Actually, just out of curiosity, how many people in this room are aware of the All of Us research program? Oh, awesome. Great. Okay. So here's the biggest picture, which is that this program is a consortium, a big data effort that is nurturing partnerships with 1 million participants around the country, reflecting the diversity of the United States. Its goal is to deliver one of the richest biomedical data sets that we have seen. And as you'll see, we've made some substantial progress in that area. And also to catalyze an ecosystem of researchers and folks who can make use of these data in all kinds of directions that are going to advance human health. So, as I said, the top line goal is to engage and enroll 1 million or more participants from across the United States. Already, nearly 850,000 people have joined the program, and more than 630,000 now have data available to researchers in the researcher workbench, which I'll say more about in a moment. And one of the things that is unique about this data resource is that more than 80% self-identify as members of communities that have been underrepresented in biomedical research. That includes a lot of different kinds of categories. For example, lower income, lower education, rural geography, age greater than 65 or under 18, race, ethnicity, and so on. So it is a, by design, very diverse data set. And I'll just give you an overview of sort of what happens when somebody enrolls. They undergo a pretty extensive consent process, which is done effectively digitally, although with often in-person guidance. And then there are a series of surveys. Some of them are administered at baseline and then subsequent surveys over time. And they cover a very broad landscape. And these are continuing to be developed and deployed. But things like lifestyle, family history, overall health in all domains of medicine, social determinants of health, as well as mental health and well-being measures. And that actually, the initial tranche of those data, I'm happy to say, were released just last month. People also provide physical measurements. These are mostly anthropometric measurements, blood blood pressure, heart rate, height, weight, BMI, etc., and biospecimens or biosamples, which include blood, urine, and or saliva if blood is not a possibility. And then a subset of folks have actually contributed to a growing resource of wearables in the form of Fitbit data. And I'll say more about that as well. And the hope is that that's going to expand also. And the data are, by design, meant to be broadly available. And the data structure is that there are 3 tiers of data. There is what's called the public tier, which is actually available to you now. You don't need any kind of login. You could go in. And what this provides a sort of aggregate level data. How many people have this condition? How many people are above this age, et cetera? And there are some nice interactive, visualizations that are very helpful there. So it gives you a sense of, what's the scale and diversity and scope if you're planning research studies, for example. Then there is the research workbench, which has itself 2 tiers. One of them is the registered tier, and the other is the controlled tier. And the controlled tier is the highest level of sort of security and also contains the broadest range of data. But basically now you have access to electronic health records, to the wearables, the surveys, basically all of the individual level data. And in the controlled tier, genomic data and some of the other data types that are not available in the registered tier because they're maybe a little bit more sensitive potentially. The researcher workbench is in a cloud-based platform, and if you haven't seen it, you can get a sense of it even if you don't become a registered researcher by sort of going to the website and looking at some of the visualizations there. But one of the really nice things is that it has most of the major analytical tools that people use are Python analyses in Jupyter notebooks that are shareable, and a fabulous user interface that allows you to build cohorts, select variables, sort of in a, to some extent, point and click kind of way. And the model here is what we call a passport access model, which is different from a lot of other large-scale data sets that people may have used, for example, the UK Biobank or many others where there is access. But often what you've had to do is define a very specific project, outline the very specific variables that you're going to use, sign something that says you will not do anything else, and then you can have access to those specific data types. But we know that that's not quite the way research works. Different ideas emerge, or you have an initial look at the data and realize there's actually a different variable that would be essential to control. So the passport data model is, yes, you propose the initial idea. It's made public, actually. But you then have access to the data and can adapt as time goes on. If you're doing a very different project, you have to sort of, describe that as well. But it's an incredibly versatile, flexible kind of framework, and no separate IRB approval is needed because the All of Us IRB has already approved the research, the participants have fully consented, and so on. So this is really, at the time, and I think it's still true, was a sort of an innovation in data access. So people can, again, access very flexibly what are the data they really need. It also supports the idea of replicability and transparency because everybody who, registers says who they are. Their project is made publicly available in terms of a summary of the project, who's working on it. You can share workspaces or make them public if you wanted to. And you've got tools sort of centrally located. The idea is that, and it enhances privacy and security a lot because instead of the data coming to all these different researchers, the researchers all have to go to a very secure enclave environment to use the data. The limitations, All of Us is not a representative probability, distribution kind of sample. And, some people don't use R or SAS or Python. And so there are some things where the program has really gone to great efforts to provide user support, tutorials, office hours, all kinds of things to make it easy to use. And there are costs after a certain initial outlay of credits that one gets of $300. But after that, obviously, the compute is something that does, in fact, cost money. Let's take a little bit of a closer look at the data set. So these are the data that are right now available, and you can see the variety. So more than 600,000 with these very broad range of surveys, more than or nearly 450,000 with whole genome arrays, and more than 400,000 with whole genome sequence. And you can see these other types as well, including structural genetic data, copy number variation, et cetera, and long read whole genome sequence. The real sort of value in some ways is the intersection of these data types. So, for example, well, I don't know where I'm looking, but you can see that in the right column on the second one there, it says greater than 317,000. So that means greater than 317,000 participants with whole genome sequence, survey responses, EHR data, physical measurements, a very broad range of data available. The Fitbit wearable data are so far available for a subset. Originally, the program rolled out a bring your own device kind of thing where participants, including me, happened to be wearing a Fitbit and sort of connected the data, but also another initiative that actually distributed Fitbits. And so there is a growing repository of this kind of wearable data over a period of years now. And a process that is in progress, which is going to, I think, dramatically enhance the kind of research that can be done, is the Center for Linkage and Acquisition of Data, which is essentially an effort to link data beyond the data types that we talked about in secure ways, including allowing geocoding, environmental data, claims data, mortality data, obviously really important, and health information exchange data from other systems that the participant might have received care in. So if you wanted to get started, you could go to the data browser now, and you don't need to log in to get all these summary statistics and see sort of a landscape of what's in the data set. There are some privacy protections at that level. For example, there are no personal identifiers actually anywhere. Data counts under 20 are sort of masked so that to limit the possibility of re-identification. And you get an interface. There are many elements to this. I'm just showing you the one where you could put in a search term. Let's say it was dementia, and it will show you where that appears in the data. What are the fields? What are the diagnostic codes, the survey, relevant survey measures, et cetera. You can then sort of look at, here's a screenshot of another visualization in just the top level data browser, asking, what are the top 10 conditions in the data set, pain being number one, according to, the EHR codes. And you can hover over these to get more detail on the breakdown by, sex, age, etc., and also the elements that went into that count. You can look at the actual surveys. So if you wanted to know, well, how did they collect these data? What did they measure? Press a button, download the survey. You immediately see what was included there. And the genomics are associated with visualizations that make it very easy to explore the data. This is an example of the data browser for genomics that shows you information about the variants, what their allele frequencies are, the diverse ancestry involved in the data set, and then you can look at functional annotations of the genetic variants and so on. A couple of examples of how the genomic data have already been used in pretty impactful ways. There was a paper in Nature last year with the initial release of whole genome sequence data and, just some initial analyses. And the data set identified more than 1 billion genetic variants of which 275 million had not been previously reported. 275 million previously unreported genetic variants. On the right side, that is a paper from Nature Medicine in which the eMERGE network, which is actually looking at the implementation of polygenic risk scores, which are genetic risk scores that sort of aggregate an individual's risk of disease, into clinical practice. And there are lots of issues we could talk about in terms of how do you make that equitable? How do you make sure that differences in ancestry don't confound the risk information you're giving to patients and clinicians? And so the All of Us data set became essential for sort of calibrating these across ancestry and validating their accuracy. I mentioned the passport model. There is an institutional data use and registration agreement that basically covers an institution at a time. So, for example, I'm at Mass General Brigham. We have an agreement. I don't have to execute my own data use agreement by virtue of being at the institution. That is covered. I mentioned that there are some initial credits, but then after that, compute costs. And there is a mechanism available in the workbench and in the cloud environment to sort of then set up billing accounts. And this is just an overview of some of the tools that are available. So there are workspaces where you can, which sort of house your data and analyses and projects. And again, you could collaborate. You could make those available to another user, let's say at your institution who you're working on this with. There's a cohort builder, which you can specify. I want people over the age of 65 who's had cholecystectomy and are on a statin and whatever. Build that cohort, and then I want an equal number of people who are matched controls. You can access, obviously, the analytic tools. There are some workflow tools that are also available and scripts that have previously been written that can streamline analyses. And there is a tremendous user support hub, again, with a lot of material available to guide people as questions come up, as well as the opportunity to reach the support folks or go to office hours or all kinds of things. The other thing that you will see there is, and this again doesn't require login, is the research projects directory. So again, in the interest of transparency, the program has cataloged every research project that has been registered. You can see as of a few days ago, it was more than 17,000. And when I put aging in the search bar, because I thought that might be relevant here, you can see that there are 489 projects that are studying aging, at least based on what's been submitted there. But you can look at every single project that is registered there, who's doing it, what are some of the goals of the project, and so on. There are more than 15 or 16,000 researchers currently working on the data set. Another thing that is very, I think, important about the study is that it is essentially a backbone for all kinds of other studies. One of the things that makes it so cost-effective is that you've got this cohort, lots of data, but then also the opportunity to have ancillary studies that build off of that. One of them is nutrition for precision health. And this is drawn from participants in the All of Us program who then consent to this ancillary or partnered research study, which itself has 3 tiers. One of them is a sort of very broad examination of detailed diet and physiologic responses to meal challenges, and then progressively more intensive phenotyping up to the live-in diet study, which is short-term domiciled data collection where people's ins and outs, let's say, are collected in their entirety. And the goal here is to develop precision nutrition and to use AI, for example, to see if we could identify what are the most important ingredients and diet composition to advance health. Another one more recently is the Exploring the Mind partnered research study. And this is one that I think, again, creates a very unique data set, especially linked to all these other data types. And effectively, it is testing transdiagnostic cognitive and emotional and social cognition functioning using kind of gamified tasks that are very well validated of attention span, decision making, response time, and response accuracy, and emotion recognition. And those data are now, the first tranche of those data are now available as well. And just I'll close by, I looked for something that might be of interest here that's used the data. This is a study from our colleagues at Vanderbilt largely. And they were interested in, generative AI and drug repurposing. And so what they did here was create a series of iterative queries for ChatGPT, asking it in I guess, more nuanced ways over time in these iterations to recommend what would be the top 20 candidates that might be relevant for Alzheimer's disease repurposing. They took the top 10 and then tested them in a sort of nested kind of cohort or retrospective cohort in All of Us and the Vanderbilt EHR, and looked at time to event analyses in which they, looked at the relationship between drug exposure prior to age 65 and later risk of Alzheimer's disease. And, there were several that appeared to be promising candidates in that way. Metformin, losartan, if you look at sort of their aggregate overall, um, statins, et cetera. So just an example of how you might, and I suspect this analysis didn't take that long. If you wanted to do a genome-wide association study, which, I'm 12 seconds over. If you wanted to do a genome-wide association study, which, before, well, wasn't even possible maybe 20 years ago, but 10 years ago might have taken you, I don't know, a week or two, you can kind of do that in, probably 30 minutes at this point. So I think it is something that hopefully everybody will become more and more familiar with. The goal is very broad crowdsourcing of science to make advances and make these kinds of things available to people in the most, usable and productive way. And I think that is my last slide. Thank you.